So I've mentioned risk a few times in the introduction. And when we talk about prostate cancer risk, what we're talking about is the risk that the cancer might actually get worse. And what that means is the risk that the cancer might spread to other parts of the body and eventually become lethal. Now, there's a number of factors that we look at in trying to identify and sort out what is low versus high risk prostate cancer. The first is the PSA. PSA, of course, is prostate-specific antigen. If you're watching this video, you have almost certainly had at least one of these tests done. This is a blood test, which we use initially to screen for prostate cancer. Historically, we used 4.0 as a threshold of what's a normal versus an abnormal PSA. Today, we realize that it's actually really much more nuanced than that. The median PSA for men at age 45 is around 0.7. By the time he gets to age 60 is around 1.0 and drifts up from there. So 4.0 is actually already a somewhat high threshold. But in the spectrum of men with prostate cancer, lower is better. And generally speaking, under 10 is where we define low risk. Usually speaking, higher PSA indicates higher risk cancer. But lots of other things can make the PSA go up. PSA is prostate-specific antigen. It is not prostate cancer-specific antigen. And anything that happens to the prostate as you get older can affect the PSA. The most common thing is just that the prostate grows. You get what's called BPH, benign prostatic hyperplasia. Infections can do it. Inflammation or prostatitis can certainly rise the PSA, sometimes chronically over the long term. Any sort of trauma like long bike rides can do it, or of course it can be cancer. Now the PSA density acknowledges the fact that if you've got a big prostate, you have a reason to have an elevated PSA just by nature of having a lot of prostate tissue making PSA. So PSA density is simply the PSA divided by the size of the prostate as measured by either an ultrasound or an MRI. And we use different thresholds of PSA density to try to identify higher versus lower risk. Generally speaking, we like to see it under 0.15 or so, even more if we can see it under 0.12. This is very important because if you have a PSA of 5, that may seem slightly high for the general population, but if that's in the setting of a 50-gram prostate, which is only twice normal size, your PSA density is 0.1, which is quite low. Now, one of the most important drivers of prostate cancer risk is the Gleason score. This is how the cells look under the microscope. When the pathologists get the biopsy tissue, they look at all of it. They say, in each core, is there cancer or not? And if there is, does it look aggressive or not? Now, there's different ways to read out the Gleason score. Historically, this has been read out on a 1 to 5 pattern scale, and 2 different patterns are assigned to each core, recognizing that prostate cancer can be quite heterogeneous within a given patient and even within a given biopsy core. So the first number indicates the most common pattern. The second number indicates the highest pattern. Generally speaking, pattern 3 is low grade, pattern 4 is intermediate, and pattern 5 is high grade. So for example, a Gleason 3+4 means it's mostly low grade cancer with some intermediate grade. Now, more recently, pathologists have been reading out grade groups, which are meant to try to simplify the Gleason scoring system down to a 1 to 5 scale, which I realize can get confusing because both the patterns and the groups are on this 1 to 5 scale. But this is the breakdown here. Gleason 3+3 is now called grade group 1 or GG1. 3+4 is grade group 2, 4+3 is group 3, 4+4 is group 4, and any pattern 5, so 4+5 or 5+4, puts you into grade group 5. Now, there's other things that we read out on the pathology report, which are also quite important. First of all, there's the question of how much cancer is there. A typical biopsy template is anywhere from 10 to 14 cores, and these days we will take additional cores if we see lesions on MRI or ultrasound. So it stands to reason having just 1 core positive is less of a risk than if you've got 10 out of 14 cores positive. Sometimes the pathology report will also read out how much of each core is involved with cancer, which can also be useful information. But details really matter. There is certainly an extent to which you'd rather have 10 cores of Gleason 3+3 than 1 or 2 cores of Gleason 4+5, because it's the fact of any amount of high-grade cancer that can really make the cancer likely to spread early. Now, when we look at Gleason pattern 4 in particular, there are more details that matter, which is the different patterns. So there are several different patterns, different appearances of the prostate glands under the microscope that are all grouped together into pattern 4. Some of these are not that concerning. When we see so-called fused gland or poorly formed gland subtype pattern 4, this actually behaves not that differently than pattern 3. On the other hand, when we see so-called cribriform pattern. This is more concerning, especially if it is in expansile cribriform or large cribriform. And then there's another version called intraductal, which is even worse. And these are all categorized within Gleason pattern 4. So the details really do matter. And it's also very important to make sure that pathology slides are re-reviewed by prostate specialist, subspecialist expert pathologists. And we do that at UCSF, as do many other medical centers. Now, what about clinical stage? So this is actually not one of the most important in prostate cancer relative to many other cancers, at least in terms of the T stage. So the stage of the cancer describes the growth extent of the cancer. The T stage is how much it's grown within the primary organ where it started. N stage is whether it's into lymph nodes, and M stage is whether it's metastasized to other parts of the body. So the T stage for prostate cancer really refers to whether it can be felt on a finger exam. And that's still the standard of care today, even though we are doing more and more imaging. So technically speaking, if you cannot feel a tumor but can see it on MRI, that's still a T1 tumor, meaning it can't be felt. If we can feel it, but there's no sign that it's outside the edge of the prostate, that's a T2. If it's outside the edge of the prostate, that's a T3. If it is into the bladder, that's a T4. And then if it's in the lymph nodes, that's an N1. And if it's gone to other parts of the body, again, most commonly the bones, that is an M1 cancer. So we put all this together in risk stratifying prostate cancer. So good risk stratification will account for all these factors together to try to give a given man with a diagnosis a sense of how much he does or does not need to be worried about a given diagnosis of prostate cancer. Now, there's lots of ways to do this. The most common one is this risk grouping system from the NCCN. There's another version put out from the AUA. This has honestly gotten relatively cumbersome and is not that accurate. There's a lot of variation in terms of actual risk within each one of these categories, especially within the intermediate risk categories, and even within high risk. As we said before, you can have a high PSA just from having a really big prostate. So you can have a PSA 21 grade group 1 tumor, stage T1, and still be technically high risk just because you've got a big prostate and therefore a high PSA. This is not a good way of doing risk stratification. The very low risk group in particular, we really don't even find anymore. And in the updated AUA guideline, this is no longer even subclassified. Everybody with low risk disease, whether or not they meet criteria for very low risk disease, should really be thinking about active surveillance as the first choice for treatment, except in pretty unusual circumstances. Now, there are better ways to do risk stratification. This is the Capra score that we published at UCSF back in 2005. This has been validated all around the world in dozens of different studies and has repeatedly been shown to be quite accurate in stratifying risk. This is quite easy to do. It's the same typical variables: PSA, Gleason, T-stage, the percent of biopsy cores involved, and age. You add these up for a 0 to 10 score, which is very accurate in terms of stratifying likelihood of actually dying of prostate cancer over the next 15 to 20 years. And what you can see from this graph here, you want to stay at the top, meaning very low likelihood of dying of cancer. Capra 0, basically nobody dies to 15 years, very few with Capra 1. On the other hand, those with bad cancer, Capra 9 and 10, 50% of these men actually die of disease within 10 years. This is fortunately not that common. We find many more low-risk cancers than high-risk cancers. And this, by the way, is about 85% accurate. So if you ever hear comments that we cannot tell aggressive from non-aggressive prostate cancer, that is just not true. Now, do you need additional imaging beyond whatever was used to diagnose the cancer? The answer is it depends. Historically, we used bone scans to look for disease in the bones, and CT or MRI to look at the lymph nodes. These days, we're really using MRI as the primary local staging modality along with ultrasound. So this is the best ways of determining whether the cancer has spread outside the capsule of the prostate in terms of local extent, whether we see a T3 tumor. And then to look for cancer in other parts of the body, there are a variety of different PET CT scans that are available. In 2023, the one that has really taken over is called PSMA PET scanning. This can be done as a PSMA PET CT or PET MR. It's able to look at both bones and soft tissue and is definitely the most accurate test we have ever had for distant staging of prostate cancer. Now, even a PSMA PET does have its false positives. You have to watch out for things like a single spot showing up in one rib, and there are false negatives. Even a PSMA PET cannot show us microscopic disease in lymph nodes or in bones. So this is still not a definitive test, but it's the best one we have ever had. And not everybody with a diagnosis needs a PSMA PET. We really reserve it for men with high-risk disease or those who are at the higher end of the intermediate risk range. Now, what about genomic testing? So this is looking to see what makes the cancer tick at the level of the genes. So you've got the same DNA in every cell in your body that you inherited from your parents. And what tells the cell, this is a prostate cell versus a brain cell versus a blood cell, is which sets of genes are turned on and turned off in a given cell. Now, what makes it cancer is dysregulation of those genes. You get growth signals that are on when they're supposed to be off. You get mobility signals that are on when they're supposed to be off. You get regulatory pathways that are turned off when they should be on. And we can start to interrogate these pathways. We can start to count up the number of genes that are incorrectly regulated and make more precise predictions about which cancers are likely to be aggressive versus not. The ones that we've used most over the years are Decipher, Prolaris, and Oncotype. These are all looking at RNA expression, at gene expression in prostate tissue that we get from biopsy. The one that we're using overwhelmingly these days is the Decipher, because it's giving us a look at the whole genome, all 30,000 genes, which gives us a lot of information about how the cancer might behave over years to come. In some cases, if you have a strong family history of prostate cancer or certain other risk factors, we may also recommend genetic testing. This is looking to see whether there are any mutations in the DNA that you were born with that might set you up for having developed the cancer in the first place. Things like BRCA mutations, ATM, CHEK2, etc. Although only in unusual circumstances is genetic testing actually dictating what we are doing for you with localized disease.